one is Dr. Niraj Kumar.
A very good evening to respected panelists and August gathering. I am presenting a comparative study of canalicular silicon tube intubation in patients with chronic dacryocystitis cystitis. The introduction: chronic dacryocystitis cystitis is an infection or inflammation of nasolacrimal sac, usually accompanied by blockage of nasolacrimal duct. The common cause of failed DCR are stenosis of the common canaliculi, closure of the sac mucosa anastomosis by fibrous tissue, post-surgical procedure. The aim and objective of our study was to compare the overall surgical outcome when silicon tube is removed at 4 weeks versus when it is removed at 6 weeks after intubation. The inclusion criteria are failed cases of DCR surgery with EP4A and absence of any gross nasal pathology. Materials and method. It was a prospective single-centered study conducted at Tertiary Care Center. The duration of study was 2 years and the sample size was 60 patients that were divided into 2 groups, 30 patients in each group. Group A contains in which the silicon tube was removed 4 weeks after surgery, and in group B, the silicon tube was removed 6 weeks after surgery. The ocular examination including inspecting the sac area for swelling, lacus tear meniscus height, position of puncta and rhoplaz. Careful lacrimal syringing was done through the upper puncta to confirm the diagnosis. All patients underwent redacryocystocystomy surgery with silicon tube intubation and application of mitomycin C 0.5 mg per ml over the flap and circumostial region. Re-DCR surgery was done with silicon tube of 20 gauge was introduced from the inferior puncta and passed through the middle meatus to the ipsilateral nostril and tied with the canalicular free ends. Mitomycin 0.5 mg per ml was applied on the proposed flap and circumostial region for 3 minutes. Post-op patients were advised to dial the silicon tube with application of eye ointment moxifloxacin. The follow-up was done in both groups on post-op day 1 and at first week, 4 weeks, 8 weeks, and at the end of 12 weeks. The results were analyzed at the end of 3 months to decide the outcome of surgery. These photographs are the post-op images of the patients. The results. The result of our study is the proportion of gender distribution were 65% females and 35% male. Maximum number of 70% patients lie between the age of 30 to 60 years. Minimum number about 10% of patients under 30 years of age group. The success rate of surgery in group A was 90%, while in group B it was 100%. Chronic dacryocystitis was associated in 18% cases with conjunctivitis and 15% cases with sinusitis and 25% cases of meibomian gland disease. 72% of patients complains of first episodes of chronic dacryocystitis. 10% patients complains of watering on post-op follow-up on 3rd month. Transient punctal erosion was seen in 2 cases that resolved spontaneously in 4 weeks. Chronic nasal irritation and congestion in 4 cases resolved after silicon tube removal. The main cause of failed DCR surgery was the blockage of common canalicular opening, deposition of fibrin and inflammatory debris that lead to early fibrosis and closure. The optimal time for maximum success rate is 6 weeks to achieve the adequate tissue healing and remodeling, beyond which increase in the risk of infection and punctal erosion can be seen. The conclusion of our study is the success rate of DCR surgery with silicon tube intubation is higher in group B with statistically significant difference. To achieve the best outcome, silicon tube intubation should be kept for 6 weeks. Thank you.
Okay, nice presentation, but you did monocanalicular intubation?
Yes, ma'am.
Not bicanalicular?
No, ma'am, bicanalicular no. Ma'am?
Why?
Because keeping this tube like this hanging, for how many weeks you say?
Ma'am, for 6 weeks.
So it's that's very difficult
Very
for the
difficult
patient,
to maintain.
and why not the usual method of bicanalicular intubation?
Ma'am, because the patient, because it's required the dialing of the patient to prevent synaptic formation. In rural areas, they are not maintain so much of hygiene, and it is easy to dial the, if it is traumatized, So the only, the major drainage occurs through the inferior puncta. So we want to.
Second thing
make
is
it-
failed TCR cases. Usually punctal stenosis is not the cause for failure.
Ma'am, not only.
Fibrosis of the main lacrimal duct.
Yeah, yes, ma'am.
But
Ma'am,
why to deal with the punctal stenosis and putting the silicon tubes to lower punctum and lower canaliculus, not through the upper, and difficult to maintain the.
Ma'am, because the probing, we felt a soft stoppage, and we assume that the patients are earlier operated at different centers. They come here.
But dialing is not a routine, it's not a recommended thing. We don't dial.
Dialing,
At least I don't. Plus, I have never read
No,
in
I don't
literature.
think many people do it. It worked for you. I just feel that between 4 weeks and 6 weeks, it's a very small difference really to say that it could be so significant. And you should also write in the title of your study that it is patients with failed DCR, because that is the main idea, that it is a failed DCR and these are your modifications so that it doesn't fail. So that's important to put in your title. Thank you, doctor. We'll go to the next.